case brought up. We'll talk about a young, I have no financial interests, a 13-year-old Caucasian male brought in to rule out a possible retinal and or macular dystrophy, 3-month history of non-progressive visual impairment, no pain, no trauma. Had been examined at an outside clinic about 6 months earlier, and the report was a normal macula retinal examination. History of ADHD, depression, etc. Medications as listed, and I put down the indication of medication since these are medications we don't always encounter in our ophthalmic practices. No significance, this young gentleman attempted suicide and depressant medication about 2 months earlier as well. Vision was down 20/50 and 20/60. Anterior segments are quiet. Vitreous cavities are quiet. There's no cellular flare. And you see the posterior poles here both show some pigmentary deposits and a little bit of pigment atrophy centered in the macular regions bilaterally. Red-free highlights those changes, but I think you'll see here angiographically, now we have the areas of blocked fluorescence along with mottled hyperfluorescence, right eye, left eye, a couple of streaks there as well. And so the question arises, here's the OCT showing some vertical areas of abnormality, but quite good preservation of the foveal contours, and just matching up some images here. So I have a young gentleman who attempted suicide. He's been on an array of medications, sent in for a possible macular dystrophy.
Laser.
Laser. I didn't mention laser, Rich. What are you talking about with laser?
I think he might have been staring into a highly powered Chinese-produced internet bot.
You're going to cause some international problems, so Rich, you start to.
That's true.
Other comments? Other thoughts?
I think he's right on. That's the diagnosis here. And I ask the patient, do you have a laser at home? That's the first question I ask. And sometimes they deny it, and then you talk to their parents, and they tell you he has a laser.
That's a question that we certainly did ask. So just going to take a step back for a second. The attempted suicide we felt had no role in this. The medications he was on played no role. We did not believe he had any type of an inherited retinal or macular dystrophy. So the bottom line is that there is a little bit more of the story. And here's the exam once again showing the left eye highlighted by that little streak. And the little streak caught our attention that was probably a little spillover of a laser-inflicted injury. So we did ask that one question he suggested. But the question was asked to the parents, does your son have access to a laser? And the answer is yes, powerful green laser. The child was asked directly, did he inflict this himself? Of course, the answer is always no. I've never had a patient really admit the fact they've done this, but this is certainly very much compatible with his diagnosis of a self-inflicted laser maculopathy. And the setting here is all too typical, a young, somewhat troubled male patient who comes in. This is the typical OCT features, these outer retinal disruption of vertical hyperreflective bands. We see this and the pigmentary change in a somewhat non-specific pattern along with streaks. These oftentimes, of course, are repetitive episodes of use. So typical patient, male, under the age of 20, oftentimes a delayed diagnosis, multiple sessions of exposure. These laser pointers, of course, can be bought online. About a third of the patients do quite well visually, but some of them do suffer significant permanent visual impairment. Plan number one here, of course, take the laser away from the patient. That was done by the parents. When you see this patient, if you see a patient that's acutely, do steroids play a role? That's not really known. This patient came into us quite some time down the road. We've asked this patient back. Unfortunately, the parents have not brought the child back in, but they indicate that he is doing well. But of course, we can't interpret how well that means. Laser maculopathy, there's different classes of lasers. Most laser pointers are so-called class 3. These, of course, can cause eye problems. But look at advertising done online. You can buy this laser in a Hunter's. Look at the setting there. This is super bright. You see in the daytime, it can start a paper on fire. So think what it can do to your eye. Of course, this is pointing into your eye. We don't know the exact laser pointer that this young patient had, but certainly enough of a problem to trigger the problem. So bottom line, look for these hyperreflective bands in OCT. Always be suspicious with your history. The setting, of course, young male, oftentimes troubled patients. No real standard of care for treatment per se, except just to take the laser away and follow the patient. So I want to thank our panelists for their cases. Hopefully this provides some insight into things that we see routinely. We love these mysteries in our clinics, and oftentimes it does lead to a positive diagnosis.